All right, let's go ahead and get started for today's grand rounds. Dr. Mesa was going to introduce me, but I think he's maybe delayed because of the weather, so I'll introduce myself. I think I'm qualified. So I think most of you know me. My name is Gilles. I'm a fourth-year pathology resident. And today I'll be talking about some of the projects I did with him and others with the VA pathology lab. In case you're wondering about the picture of my title of my talk, I was originally scheduled to give this talk in November, and I was giving it on testicular tumor, so I thought it was fitting to do a November theme, but it's no longer November, and I don't really have time to go into it. But I will recommend watching the TED Talk on the subject because it's very interesting. Nothing. So what I'm going to talk about today is I'm going to review briefly the anatomy and the histology and the embryology of the testicle as it pertains to this talk. Likewise, I'm going to do the same thing and give an overview of the subject of sex-cord stromal tumors of the testes, really just as it pertains to this talk. And then I'm going to go into some of the projects that I've been involved with. First looking at some benign testes, then some Leydig cell tumors and androgen-producing cells, and then some Sertoli cell lesions, and wrapping up with trying to summarize the key points, which I'll actually do more so integrated after each part. So reviewing the normal anatomy, histology of the testicle. As we all know, the testicles are paired organs that sit in the scrotum and the external genitalia, and they are encased by this fibrous layer called the tunica albuginea, which invaginates at the hilum to form the mediastinum testes and the rete testes, and then has several invaginations through the outer surface to divide the testicle into lobules of seminiferous tubules, which then drain into the rete testes, exits the testicle through 6 to 8 efferent ducts, which coalesce in the epididymis and flow out through the vas deferens. So if we look at the histology in cross-section, we see all the seminiferous tubules back to back with little interstitial space composed of Leydig cells, which are the endocrine function of the testicle. So the testes has two main functions, reproductive and endocrine, and the endocrine function, as I was saying, is carried out by the Leydig cells primarily, and the reproductive function is done by the seminiferous tubules. So if you look at the seminiferous tubule and cross or upright, we see the Sertoli cells and then the germ cells going from the primary spermatogonia to the mature spermatid on top, and that's all coordinated by the Sertoli cells. And reviewing the basic endocrine and endocrine coordination of the testes, it's performed through the hypothalamic pituitary axis, which secretes FSH and LH, which act on Sertoli cells and Leydig cells respectively, and then is controlled by negative feedback via androgen hormones and inhibin. So the embryology of the testes is that it develops in the retroperitoneum through a structure called the gonadal ridge, which is paired in the retroperitoneal space, and it sits next to the aorta and the suprarenal primordium, or the adrenal, and the mesonephric ducts sitting back here. So this is kind of the textbook embryology that has been taught forever. But in the mid-90s, they came up with good evidence studying SF1 transcription factor that prior to the gonadal ridge, these were actually arising from a common embryologic origins as the adrenal gland called the Adrenogenital primordium. In about the fourth week of gestation, the germ cells migrate into that from the yolk sac and then undergo differential development, leading to two distinct structures. This is just showing a timeline of the testes and ovary development during gestation, and again showing the divergent embryologic origins for these two structures and the different cytokines that are implicated in that process. So So again, they're developing in the retroperitoneum space. This is a 54-day-old embryo with the testes highlighted here. And then under, or by differential growth, they will descend and go down inferiorly through the inguinal canal and into their final destination in the scrotum. And in doing so, they bring their lymphatic and blood supply with them, which is clinically important because they therefore will drain their lymphatic flow to the retroperitoneal and para-aortic and para-caval lymph nodes as opposed to the inguinal and pelvic lymph nodes. So if you have a positive inguinal or pelvic lymph node at the time of orchiectomy, that's actually a metastatic disease as opposed to a regional lymph node disease and would be staged as such unless the integrity of the scrotum has been disrupted via or biopsy or something, which is the reason they don't do it, and they just go straight to orchiectomy. So now I'm going to talk about a brief overview of sex-card stromal tumors. And as you can see, this is actually all non-germ cell tumors of the testes, which was conveniently laid out in a recent review in the new edition of the WHO classification of genitourinary tumors. And this summarizes the non-germ cell component of that. So as we see, we have several tumors: Leydig cell tumors, Sertoli cell tumors, and granulosa cell tumors, the common sex-card stromal tumors that we'll talk about, as well as fibromas and fibrothecomas and others that we won't talk about much today. And then I put this in again just to show that there's blood vessels and everything. So anything that leiomyomas, angiomas, and things that happen elsewhere can also happen here, as well as hematopoietic neoplasms, which obviously happen everywhere. And Sertoli cells tumors are kind of unique in that there's several variants that have been historically distinct entities, such as the large cell calcifying Sertoli cell tumor, the sclerosing Sertoli cell tumor, and the lipid-rich Sertoli cell tumor. However, with this new edition of the WHO, they took out sclerosing Sertoli cell tumor and lipid-rich, so those are no longer considered distinct entities, with the reasoning being that at least the sclerosing subtype harbor common mutations in the beta-catenin gene, similarly to the Sertoli cell tumor NOS. So for that reason, it's no longer considered a distinct entity. Large cell calcifying Sertoli cell tumor is still considered a distinct entity because it usually arises in Carney complex and has a different pathogenesis. And similarly, intratubular large cell hyalinizing Sertoli cell tumor, also a distinct entity because it arises usually in Pelletier syndrome. It has a different pathogenesis. So as a group, these tumors are extremely rare. They represent only 4 to 5% of testicular tumors overall, which are not that common. A little bit higher in the pediatric population, probably not because of an increased incidence, but because germ cell tumors are less common. Usually present as a mass because it's in the scrotum. It's usually palpable early, can have pain, and if it's a Leydig cell tumor, it can have hormonal manifestations such as gynecomastia or Cushing's syndrome. Rarely these things are reported to be malignant, so it's often quoted in textbooks at 10%. But because these are so rare, it's kind of hard to study, and that's probably an overestimate. And because they're usually benign and usually are and extremely rare, nobody really cares about them, so there's not a lot of literature on them. When they are malignant, there's good histologic classification schemes for predicting malignant potential, which is the same histologic features we look at in any tumor: infiltrative borders, big size, cytologic atypia, high mitotic rate, necrosis, or lymphovascular invasion. And if they do develop metastasis, they behave extremely poorly because they do not respond to any of the chemotherapies or radiation regimens. A couple of tumors I'm going to talk about are the testicular tumor of adrenogenital syndrome and the testicular adrenal rest tumors. So depending on what text you read, they may be classified as the same thing, but if you separate them, it would be based on whether or not they're arising in the context of adrenogenital syndrome, which again is malfunction in the congenital biosynthesis of glucocorticoids. So you're not able to push steroids into the glucocorticoid pathway, so you get increased ACTH, which then everything gets shunted into the androgenic pathway. You have high levels of androgens, which cause virilization in a female, or usually precocious puberty in a male. So one of the things I forgot to mention on the embryology is because these are the testicles do arise from the common precursor embryologic origin of the adrenal gland, is they can have remnant adrenal cortical cells kind of throughout the abdomen and more commonly within the testicle itself. So similar to a paraganglioma being an extra adrenal manifestation of the medullary component of the adrenal, the cortical component can do the same thing. And if you develop neoplasia out of that, you develop one of these syndromes. And it's important to distinguish these because they do respond to dexamethasone suppression of ACTH or hormonal therapy. So I'm going to run through a couple examples of some of these tumors. So this is a Leydig cell tumor. Usually these are well circumscribed grossly, kind of brown, mahogany colored. And similarly on histology, they remain well circumscribed for the most part. These are some benign Leydig cells. They usually have a sheet-like architecture composed of a very monotonous population of cells with abundant eosinophilic cytoplasm. And they characteristically have these pathognomonic Reinke crystals, which is helpful if it's there to diagnose that it is for sure a Leydig cell tumor. And the other thing that they have is a lot of lipofuscin pigment, which is not really represented in this example. Comparing that to the testicular tumor of adrenogenital syndrome, when it's syndromic, again, it happens in more of a diffuse manner. It's more red, hemorrhagic, grossly, and both of these adrenal-like lesions occur at the hilum. So here we see the reedy testes here, so we know we're at the hilum of the testicle. And at high power, these have a very similar morphology to the Leydig cell tumors with plump eosinophilic cytoplasm. So this could easily be mistaken as a Leydig cell tumor, especially because people don't see these that commonly. However, the differentiating features are marked pleomorphism, so we have a lot of size variation within the nuclei. So that's common with endocrine-type tumors, endocrine atypia. These tumors are also characterize these fibrous bands that separate them into nests or lobules of tumor cells. And these will also have lipofuscin pigment, but typically it's much more abundant in these tumors. Some androgen insensitivity syndrome, syndrome that you lack a functional androgen receptor. So it's usually a genotypic male with a female phenotype. In that syndrome, they frequently, 25% or more of cases will have some degree of Sertoli cell hyperplasia or Sertoli cell adenomas, which is characterized by tubules of Sertoli cells only, without germ cells. And if it forms a nodule, it's an adenoma. And these will have, with Sertoli cell lesions, typically have this kind of basement membrane collagenous deposition, which is even better represented in a Sertoli cell tumor, which is a neoplasm of Sertoli cells. And the hallmark here is that it forms tubules composed of Sertoli cells with clear cytoplasm, and again, abundant collagenous basement membrane deposition. Grossly, it's well circumscribed again, but it's more white than it is brown like the Leydig cell tumors. Another tumor that happens in the reedy testes is actually arising out of the reedy testes, called the reedy testes adenoma. And typically these are more cystic or cystadenofibromatosis, but when they're forming more solid patterns, they can easily be mistaken for a Sertoli cell tumor. So the keys here, are that it is arising within the hilum, and there's not that collagenous basement membrane deposition. The sclerosing Sertoli cell tumor I talked about is defined by more than 50% sclerosis of the lesion, and that's important to recognize because even though they don't consider it a distinct entity anymore, close to all of these cases that have been reported have been benign, so it does have prognostic value. Large cell calcifying Sertoli cell tumor is noted to be very heterogeneous, both grossly as well as histologically. And like the name would suggest, it is composed of large cells and numerous calcifications. So laminar calcifications and pseumomatous calcifications throughout this tumor. It's also has this characteristic neutrophilic and sometimes mononuclear cell response. So it seems to be kind of an inflammatory type lesion. So that's the background, kind of the overview of sex-covered stromal tumors. Now I'm going to talk about how this kind of transpired and kind of leading into the projects that I was involved in. So this is a case of a 65-year-old male who had a recurrent liposarcoma, and he was undergoing workup and found to have a nodule in his testis. And they sent it for a frozen section diagnosis, and touch prep was done and showed these plump cells with a lot of cytoplasm, and there was Reinke crystals everywhere. So it was apparent that it was a Leydig cell tumor. The frozen, likewise, was confirmatory that it was a Leydig cell tumor. And I think over the weekend, the permanent sections came back, and when the permanent section came back, there was a Leydig cell tumor, but there's no Reinke crystals present within the cells. So we thought that was peculiar. So looking at the research, what is a Reinke crystal? Well, it was discovered in 1896 by Friedrich Reinke, who was a German anatomist, and he obtained fresh tissue from a 25-year-old executed criminal and was able to find these crystals within Leydig cells by close histologic examination and close attention to detail. So this is a plate from his original study. He went on to look at 10 more autopsy cases, of which he found 9 of 11 of those cases he found abundant Reinke crystals within Leydig cells, and he went on to publish this work. So this is the plate. So in 1896, you couldn't just pull out your cell phone and put it up to the microscope objective and take a picture. You had to hire an artist to draw you a picture, and this is that. And then this is some of the isolated Leydig cells with Reinke crystals in them. This is isolated Reinke crystals suspended in water, unstained. The 2 cases that he did not find crystals in was a 15-year-old and a 65-year-old male. Neither of them were producing sperm. So even at this time, following this, there went on to be a lot of look into this, investigations, and even at this time they were suspecting that these cells were probably involved in some kind of hormonal processes. So this is him at the Anatomical Institute of Rostock, Germany, where he studied. This is him on the right as in his younger years. So here's an EM of his Reinke crystals, and then he's also notable for discovering the Reinke space in the larynx. For some reason, he had a great interest in the larynx, and so the Reinke space is the space between the vocal ligament and the overlying epithelium, which is thought to have some reverberation effects and plays out in sound. This is Franz Leydig, who discovered the Leydig cell in 1850, so 46 years before the subsequent discovery of the Reinke crystal. And as you can see, the histologic preparations at this time were not as good, so discovering the Reinke crystals would be tough. So after reviewing the literature, it's noted to be that Reinke crystals are reported in only 1/3 of Leydig cell tumors, and even more rarely in benign Leydig cells in normal testicle. And because he originally wrote his paper with a lot more incidence of them, and he used alcohol as a fixative. We hypothesized that this was the low numbers that are reported in the literature today are probably due to degradation or dissolution within formalin fixation. Similarly, because they're only present in androgen-producing cells, we thought they were likely represent a form of crystallized androgenic hormones or androgenic enzymes. So today they've not actually been biochemically characterized. So we prospectively procured testicles from the next essentially 21 male autopsy cases that came through the VA, and we took 5 sections and put them into formalin, and 5 sections and put them into alcohol. And because we also had to process them through a tissue processor with alcohol as opposed to formalin, it wasn't that easy to not obstruct the daily functioning of the laboratory. Because of that, we kind of were batching them and randomly randomize them by fixation time for how much time they actually spent in alcohol or formalin. So that was an additional variable that we got to look at. We did a bunch of additional special stains to see if we could highlight them better, as well as a broad panel of immunohistochemical stains looking at androgenic hormones and androgenic enzymes to see if we could get any positivity. So if you remember biochemistry of the steroid synthesis pathway, the stuff that's unique to androgen production that happens within the testicle, turning hormones into testosterone. These are the enzymes and these are the hormones that we bought antibodies against and looked at. So these are the results. We found Reinke crystals in 19 of the 21 cases within just normal Leydig cells versus in the alcohol fixed preparations versus only 7 of the 21 cases that were fixed in formalin. So much more in the alcohol cohort. We semi-quantified the number of Reinke crystals present on each slide. So if it was less than 5, it was considered scant. Between 5 and 20 was considered moderate, and more than 20 was considered abundant. And what we found was 7 cases of alcohol fixed showing abundant crystals versus only 2 of the formalin fixed cases. And likewise, both the moderate and the scant, we found higher degree in the alcohol fixed cases. And then looking at time, they seem to dissolve with longer fixation times, as we suspected. So this is some of the examples of the Reinke crystals that we found in the alcohol fixed preparations. So as you can see, they're very conspicuous, very sharp looking. They range from numerous to a single one per cell to 0. Sometimes they're cut in cross section and give a kind of hexagonal appearance. Sometimes you find cells with numerous sharply defined Reinke crystals. Comparing them with the formalin fixed cases, after 1 day fixation, they're present in both the formalin and alcohol fixed cases, but they're much more sharply demarcated and easier to appreciate in the alcohol fixed cases. After 53 days of fixation in alcohol, they're still present and able to be identified. However, they're not nearly as conspicuous. And we wouldn't be able to find them at 53 days fixed in formalin. This is actually a Leydig cell tumor that I took a picture of. Looking around, I was able to find where I think is a remnant of where a Reinke crystal was within a Leydig cell, and it subsequently dissolved out. And here, there's a Reinke crystal present, but the edges are starting to be dissolved. So 2 of the cases that didn't have any Reinke crystals within the Leydig cells both showed burnt out morphology and essentially had 0 Leydig cells to look at. Some of the special stains we did, as you can see, they're present in all of them, but not really any more obvious than the H&E. Trichrome is sometimes reported in the literature to be used to bring them out. It's probably as good as H&E. The androgenic hormones stain the Leydig cells, but not the Reinke crystals. Looking at the steroidogenic enzymes, the only one that was fruitful was 3-beta-HSD, which stained the Leydig cells, but also specifically to the Reinke crystals. So in summary, they're much more common than is reported in the literature. Again, in the literature, it states that they're only present in 1/3 of Leydig cell tumors, and even rarer in benign Leydig cells. However, they dissolve rapidly in formalin and slowly in alcohol. And they show specific staining with 3-beta-HSD, so that's a novel finding. I didn't mention this, but Nestin was reported in a prior report to stain specifically the crystals. However, they used a polyclonal antibody, so we repeated it, and we used a monoclonal antibody, and we could not reproduce that result. And CYP17A1 was the best enzyme for determining Leydig cells versus the other components of the testicular parenchyma. So that was kind of the first project, but then now we had all these antibodies already up and running and already looked at the literature, so it was, why not continue on? So let's look at neoplasia. So we searched all the pathology databases that we had access to, so essentially through the University of Minnesota, both East Bank and West Bank, and Southdale, all the Minneapolis VA cases, and all the cases we could get from Abbott. And we just did broad searches to find as many cases we could get. And this is what we found, excluding Sertoli cell lesions here for now, because I'll get into that as the next part. But the first part, looking at androgen-producing cells, we found 20 Leydig cell tumors, 2 testicular adrenal rest tumors, 2 testicular tumors of adrenogenital syndrome, 2 cases of androgen insensitivity syndrome. So these are actually non-neoplastic cases, but we're just looking at the non-neoplastic Leydig cells within these syndromes. And then for comparative, we put in 10 non-neoplastic adrenal glands from nephrectomy specimens just to compare to, because of the common embryologic origin. Again, we looked at Reinke crystals and semi-quantified them, both in the tumoral and non-tumoral components. And we did a broad IHC panel looking at several markers that have been described in the use for the workup of sex-cord stromal tumors, as well as the androgens and androgenic hormones. This is the clinical pathologic features. Not too surprising. 2 of the Leydig cell tumors showed atypical morphology, so we separated them out a little bit. And 1 of the testicular adrenal rest tumors had a prominent lipomatous component. But mostly young-aged to middle-aged people, mostly small nodules. All of these cases behaved in a benign fashion. None of them had metastasis at the follow-up months that you see. Most of them presented as a mass, but some of the Leydig cell tumors did have hormonal manifestations. Looking at the marker, the immunohistochemistry for the common markers associated with sex-cord stromal tumors. And I'll say that most of the literature is pretty patchy on these and kind of discordant, which is similar to what we found. But Vimentin was positive in Leydig cells and Leydig cell tumors. Is kind of patchy and variably in the adrenal-like tumors, and is positive only in the zona glomerulosa of the adrenal gland. CD56, which is one of the markers that's usually used to distinguish adrenal-like tumors from Leydig cell tumors, was positive in all of them, so it wasn't that helpful. And it was positive in the superficial zona glomerulosa, the zona glomerulosa and the superficial zona fasciculata of the adrenal cortex, but not in the deeper layers. The rest of these stains were pretty erratic and not that helpful. Looking at the androgenic hormones, inhibin was positive in both Leydig cells, Leydig cell tumors, adrenal-like tumors, and the androgen-producing zona reticularis of the adrenal cortex, as would be expected. Calretinin was positive in Leydig cells and Leydig cell tumors, and negative to variable in testicular adrenal tumors, and negative throughout the adrenal cortex, as I'll talk more about. Androgen receptor, as would be expected, was negative in Leydig cells of androgen insensitivity syndrome because that's the underlying defect. It was appropriately negative. However, it seemed to also decrease the amount of 3-beta-HSD expression, which is interesting. And 3-beta-HSD was maintained in the rest of the Leydig cells and Leydig cell tumors, as well as the adrenal cortex. Also, is kind of variable in the adrenal-like lesions. So this is a stain of calretinin on normal non-neoplastic Leydig cells. And as you can see, it stains these cells strongly and diffusely, so you can't really appreciate if the crystals are staining. But if you dilute the stain a little bit, you can kind of wash out the background cytoplasmic staining, and what you're left with is more specific staining of Reinke crystals. And similar from the last paper, we knew that 3-beta-HSD would stain specifically the crystals. So it's showing both of them in a dilution phase to show the crystals are staining specifically for both of them. If you dilute them a step further, you get only the crystals staining. So bringing this all together, we see normal Leydig cells and Leydig cell tumors have a unique phenotype in that they both have high expression of both of these proteins that are staining Reinke crystals. So high concentrations of 3-beta-HSD and calretinin. And androgen sensitivity syndrome have decreased levels of 3-beta-HSD, maintain their calretinin expression, but don't have Reinke crystals. And then both of the adrenal-like lesions, as well as the adrenal cortex, have 3-beta-HSD expression, but they don't have calretinin expression, and hence don't have Reinke crystals. So it seems to take high concentrations of both of these to form crystals. This is just some of the non-neoplastic adrenal glands showing diffuse staining through all three layers of the adrenal cortex for 3-beta-HSD. Calretinin immunostain is interesting because we often use that as a marker for neoplastic adrenal lesions, but it's aberrant expression, and it's actually negative in non-neoplastic adrenal gland. Pankeratin is also negative in non-neoplastic adrenal gland with some patchy non-specific staining, but it's a little interesting because the adrenal gland cortex is actually derived from mesoderm. So it's interesting to me that we call it adrenal cortical carcinoma when we have a malignancy. Perhaps sarcoma would be a more appropriate term. Inhibin stains the reticularis. And again, looking at Reinke crystals, we found them in 18 of the 20 cases of Leydig cell tumors, so much higher than has been reported in the literature, again, of only 1/3 of cases. And then again, evaluating non-neoplastic Leydig cells next to these lesions when they were available to look at. So they were available to look at in 16 of 20 cases of Leydig cell tumors. All of those had Reinke crystals in them. 100% of the 2 cases that we could look at in the testicular adrenal rest tumors, there wasn't any benign Leydig cells in the 2 cases of T-tags, and there was not crystals present in the benign Leydig cells of the androgen insensitivity syndrome, as I mentioned. So to summarize these findings, Reinke crystals are common in Leydig cell tumors, so now we know both in Leydig cell tumors and non-neoplastic Leydig cells. And they're unique to Leydig cells and Leydig cell tumors. So in addition to 3-beta-HSD, they also show specific staining with calretinin. And this immunophenotype seems to be unique to Leydig cells and Leydig cell tumors with strong expression of both of these. So we think that Reinke crystals represent, for the most part, if not exclusively, a 3-beta-HSD and calretinin complex. And synaptophysin and CD56 that have been used are reported in the literature to be able to separate out testicular adrenal-like lesions from Leydig cell lesions. We cannot reproduce that result either. Limitations in this study. One of the things that would have been really interesting to look at would have been the ACTH receptors to compare these because the testicular adrenal-like lesions are theoretically supposed to be driven by ACTH. But multiple vendors and antibodies were tried and we couldn't get consistent results. So now I'm going to wrap up with a little bit about Sertoliform or Sertoli cell lesions. So the tubular structures of the testes include the seminiferous tubule, the reedy testes, and the epididymis. And as I was mentioning earlier, the seminiferous tubules are derived from the adrenogenital primordium versus the reedy testis and epididymis, which have different embryologic origins, and they arise from the mesonephric ducts. And these tumors are even more rare than the previous ones we talked about, and represent less than 1% of all testicular tumors, which are mostly Sertoli cell tumors. And again, given the rarity and overlapping morphology of some of these, they can create diagnostic challenges because people just don't see them. So essentially the same approach as the last one. We included 2 more hospitals now to try to increase numbers. However, that was not really fruitful because we didn't add any more cases. And subclassified these again. So 2 androgen insensitivity syndrome associated Sertoli cell hyperplasia or adenomas, 3 run-of-the-mill Sertoli cell tumors, 3 sclerosing Sertoli cell tumors, 2 large cell calcifying, and then 2 on the spectrum of malignancy. One of them was proven malignant, and one of them had some but not all of the features of malignancy. In this case, mostly heterologous components. And then we looked at the immunophenotypes of these tumors as well as the normal components and did comparative studies. So we just added in benign cases to make sure we had 10 examples of all of the different cell types. So again, the IHC panel to include endocrine, neuroendocrine, and genitourinary markers. Essentially the same panel, most of the literature reported markers, as well as the androgens and androgenic enzymes. So just showing an example of all of the different lesions. Atrophic tubules without germ cells and a fibrotic burnt out background. Sertoli cell hyperplasia arising in androgen insensitivity syndrome. Sertoli cell tumor, large cell calcifying, sclerosing Sertoli cell tumor, Sertoli cell tumor with uncertain malignant potential, malignant Sertoli cell tumor, and a reedy testis adenoma. The clinical parameters in this case, they showed a mean age of 31 years. The cases of androgen insensitivity syndrome presented at age 16, which is about right when they don't undergo menarche and get a further workup. In the Sertoliform reedy testis adenoma in a 69-year-old. The average tumor size was 1.6 centimeters, and the mean follow-up 44 months. All of these were benign except for 1 lesion. The malignant lesion was the largest of the series at 4 centimeters, and all of the histologic findings that have been reported to be associated with malignancy, including infiltrative margins, high mitotic rate, this one at 20 per high power field. The cutoff for the criteria is 3. Necrosis, angioinvasion, and epididymal invasion. And this was a case of a 59-year-old male who had Klinefelter syndrome, presented with a scrotal mass, pain in the hydrocele. At the time of resection, he had 2 positive para-aortic lymph nodes, and despite treatment, he had disseminated disease at 3-month imaging and died at 8 months. So this is kind of the cumulative results, but this is a very busy table, and 11 rows and 10 columns, 110 data points. I'm not going to go through it all. But I'll summarize some of the major findings in picture format. So in atrophic tubules, we see consistent gain of expression of proteins like CD56, pankeratin, calretinin, and nestin. In androgen insensitivity syndrome, we see calretinin, but obviously no androgen receptor. Similarly, their Sertoli cell lesions show kind of a phenotype akin to the atrophic tubules, where we see gain of expression of CD56, calretinin. Large cell calcifying Sertoli cell tumor, we have a strong calretinin expression and also some S100 expression. Sclerosing Sertoli cell tumor was the only tumor that lost inhibin expression, so that's aberrant. And also showed PAX2, PAX8 expression, which is very interesting. And then on the spectrum of malignant potential, they kind of start to erratically gain expression of markers like pankeratin and c-KIT, which can overlap with some of the immuno findings of germ cell tumors and carcinomas, so potential pitfall. And the retestis adenoma, same with PAX2, PAX8, and pankeratin, which is normal for retestis origin. Looking at the endocrine markers, most of these were not surprising, with the exception of the androgen receptor here, which is positive in all of the non-neoplastic lesions, or not lesions, but just non-neoplastic normal components of the testicular parenchyma, and then is lost in all of the lesions except for the most benign behaving lesion with the sclerosing Sertoli cell tumor. So comparing atrophic tubules to normal tubules, like I said, consistent gain of expression of pankeratin, calretinin, CD56, and nestin. And Sertoli cell tumors versus normal tubules, also variable gain of the same proteins. So comparing those two, they both have gain of expression of the same proteins. However, Sertoli cell tumor has markedly decreased loss of androgen receptor, which is preserved in atrophic tubules. Some of the unique immunoprofiles of these lesions: large cell calcifying Sertoli cell tumor showed strong calretinin expression, as well as nestin and S100. Was negative for CD56 and androgen receptor. Sclerosing Sertoli cell tumor showed the most distinct immunophenotype. And as I've been saying, nearly all of these cases have been reported to be benign. The largest study of these series done recently described two morphologic patterns, although they're very similar. One has thick trabeculae and a sclerotic background, and one has thin, delicate trabeculae within a sclerotic background. And again, we've seen PAX2, PAX8 expression in these tumors, a very unique loss of inhibin expression, and preserved androgen receptor. The retestis adenoma, as I was saying, the cystadenomas and cystadenofibromatous forms of retestis adenoma are usually easily distinguished, but when they form a solid pattern or a tubular pattern, they start to show overlap with lesions like Sertoli cell tumor and can cause diagnostic difficulty. The one case in our study stained just like a retestis origin with pankeratin, EMA, PAX2, PAX8 positivity. This is just summarizing, putting all these findings together. I'm not going to go over it. So to summarize this at the end, Sertoli cell tumor and its variants with sclerosis show a phenotype akin to atrophic seminiferous tubules. The three distinct immunophenotypes we found for these lesions in sclerosing Sertoli cell tumor, large cell calcifying, and retestis adenoma, with sclerosing Sertoli cell tumor being the most unique. Outside of the androgen receptor, none of the androgenic hormones or enzymes in this case were really diagnostically useful. Limitations for this study, obviously, these are so rare, it's really hard to find enough cases to draw a lot of meaning from. So our results would need to be validated in larger studies, which would be hard to perform. So I want to thank Dr. Mesa for all of his help and mentorship, enthusiasm through this. It's been fun. Other co-authors, Dr. Mandeville, Dr. Marugan, Dr. Dada, Dr. Khalifa for helping me jump through some of the logistics of getting cases cut here and sent over for IHC. I caused a lot of headaches in the office here, going through these logistics as well. And Liz, who helped me do a lot of searches, which was very nice of her, to find cases, as well as the VA laboratory for doing all the immunohistochemistry. So I guess I'll take any questions.
I'm David Berger, one of the pediatric pathologists.
Sure.
I just have a comment. If you are interested in finding Reinke crystals in adrenal glands, instead of looking at mature adrenal glands, you might want to look at fetal and neonatal adrenal glands that still have the fetal cortex.
Interesting.
Because that's, probably where the steroidogenic function is in the development gland.
Yeah, that's interesting.
A couple of questions. You said alcohol fix. What percentage of alcohol were you using?
I think it was 95%.
And then since you're looking at crystals, if you ever want to look at another derivative, you might consider one of the ammonium sulfate fixed derivatives like Zeus and SGilles. Not that you really have a need to preserve them any longer than you did because they held on for pretty long, but that's just another thought. And on the immunohistochemistry, you'll generally get the benefit of the doubt, but it's probably not a bad idea to mention when you make a claim like the crystals have calretinin, and you just show a positive stain, it's probably a good idea to mention that you have isotype match controls that were negative, because without controls, the positive staining, it really isn't really valid.
Sure.
And then sort of moving forward for other projects, you may be interested in, at the level of identification of the marker for diagnostic purposes, the immunostain plus minus a control suffices. But if you ever run into a situation where you mark a protein that you want to further study because it may have functional dynamic in the situation you're studying, you'll probably have to go to the next level, which is do a Western blot to show that the antibody is actually identifying the protein that you think and not cross-reacting with another protein.
Yeah. Thank you. Dr. Crossan?
Scott, I thought that was a fantastic presentation. Thank you very much.
Thank you.
It demonstrates beautifully what can be done if we are able to take advantage of all the wonderful clinical material and pathological material in the entire community and not just be limited to one institution. I've talked about this before, and I will continue to talk about it because I think we need to begin to reach out into the community and be able to utilize some of the wonderful material that's there.
Well, that's what's helpful with being a resident and having backdoor access to multiple institutions. So. All right. Well, thank you.